Welcome everyone. Let's talk about acute coronary syndrome. Acute coronary syndrome is a spectrum of clinical presentation caused by atherosclerosis, which is formed over a long period. Then it forms plaques which rupture suddenly. It is associated also with the smooth muscle constriction of the coronary artery and thrombus inside the coronary artery. This will lead to complete or incomplete obstruction of the artery. So the acute coronary syndrome composed of three main presentations: unstable angina, non-ST elevation MI, and ST elevation MI. Before that, we have something called stable angina. These patients usually they are stable. They have periodic chest pain. The pain is also radiated to shoulder, arm, back, and increase with exertion, relieve with rest. But this is usually less than 5 minutes, and the patient is having coronary vasoconstriction. This is not an acute coronary syndrome. It needs review by the cardiologist, and the patient is usually they are stable. We have to know what is typical ischemic chest pain because this is important to identify patients at risk later on. For chest pain, when you take history, what is the pain that is attributed to the myocardium is when the patient is having retrosternal chest pain. It means central chest pain, which is heaviness on nature, tightness in nature, radiated to shoulders, neck, or back, epigastrium. The pain is increases with exertion. Example, if the patient walks or runs, the patient will have severe pain. Then relieved by rest or GTN within 5 minutes. If the patient have all the three criteria, this is typical chest pain. If only two criteria, atypical. If the patient have 0 or 1 criteria, it is non-ischemic chest pain. Usually it means that the pain is not attributed to the ischemia. So the acute coronary syndrome, as we said, caused by the same disease process, by the obstruction or narrowing of the coronary artery. It's either represented by unstable angina or STEMI or non-STEMI. In STEMI and non-STEMI, there is myocardial infarction. It means there is death of the myocardial tissue and release of the troponin. In unstable angina, it is same as angina, in which the patient is having the pain radiated to shoulder, increase with exertion, relief with rest, but the patient is having the pain provoked by less exertion, increases in frequency. Previously, the patient was having pain every month. Now, every week have 3 attacks. Then, it occurs unpredictably or without exercise. The patient have prolonged episode of pain. The pain previously was only 1 or 2 minutes, now become 10 minutes, 15 minutes. Then there might be ECG change, but usually ECG is normal. In unstable angina, usually ECG is normal, but there might be some ST depression which indicates higher risk. But usually the troponin in unstable angina is negative. Why? Because the myocardium is not dead. To say non-STEMI or STEMI, both of them they are myocardial infarction, death of the myocardial tissue. So how this is defined? So this is detection of rise in the troponin, myocardial biomarkers, plus one of the following. Either the patient have typical ischemic chest pain, ST wave changes, ST elevation, depression, T inversion, or left bundle branch block, or development of pathological Q wave on the ECG. So the patient is having ECG change, having pain, having abnormal echo. There is wall motion abnormality in a region of the heart. This is also an indication. If there is troponin plus this change, it means it is an AMI. Or sometimes they may do angiography and see a thrombus, or on autopsy after the patient is died. So what is non-STEMI? Non-STEMI is when the patient having symptoms suggesting acute MI plus ECG changes, usually ST depression or T inversion, and release of the troponin, positive troponin. For STEMI, ST elevation MI, the patient have ST elevation in contagious limb lead or chest leaders. The patient have also sometimes there might be formation of Q wave. If the Q wave is formed, Q wave is defined if more than 2 millimeter depth, it means it is pathological. It means that is death of the myocardial tissue. So ST elevation or Q wave, they are regarded as STEMI, and there is also troponin release. Early effective treatment may limit myocardial damage, prevent formation of the Q wave. An example is that patient which have ST depression. So these ST depressions, they are not STEMI. So it is either if the patient have positive troponin, this will be STEMI. If the same patient is having negative troponin, it is defined as unstable angina. But you have to be careful that the troponin that is available is and commonly applied in emergency department is troponin I. The troponin I usually will be positive after 4 to 6 hours. So early presentation cannot tell you precisely whether the patient is having STEMI or unstable angina. You have to do repeated troponin tests. If you are in hurry, there is another test called high sensitive troponin. These will be positive within 1 to 2 hours and can early detect non-STEMI. So this is non-STEMI, sorry. This patient have deep T inversion, deep symmetrical T inversion, also regarded as non-STEMI, but this is a type called Wellen syndrome. This is Wellen syndrome. In Wellen syndrome, as it has another type in which the patient is having biphasic T wave, T inversion, then up like that. So these patients indicate left coronary artery obstruction, left descending artery. This patient having ST elevation in lead 1, in lead IVL, V5, viscous. So this is lateral MI, but it's also associated with ST elevation in lead V2, V3, V4. So this is anterior. So anterior lateral MI. If the ST elevation is only in lead 2, lead 3, and AVF, this is called inferior MI, inferior wall myocardial infarction. So for STEMI, you don't need to wait and send for troponin. You just give treatment and send the patient for PCI. But for non-STEMI and for unstable angina, you have to measure the heart score. The heart score composed of 5 or 6 components. 5 components: the history, ECG, age of the patient, risk factors, and troponin release. In the history, if the pain is typical ischemic chest pain, you have to receive, the patient receives 2 score. If it is moderately suspicious, non-atypical chest pain, 1. If it is non-ischemic chest pain, it is 0. For the ECG, if there is significant ST depression, receives 2. Non-specific depolarization disturbances receive 1. No ECG change, normal ECG 0. Age, more or equal to 65 2, between 45 to 65 1, less than 45 0. For the risk factors, if the patient have 3 or more risk factors, or 2, 1 or 2, 1, no risk factor, 0. You have to know that the risk factors in heart score include one of these: hypercholesterolemia, hypertension, diabetes, family history, smoking history, recent smoking history, or the patient is obese and the body mass index is more than 30 kg per square meter. So these are the risk factors. That for the troponin, if 3 times or more elevated, upper limit receive 2. 1 to 3 times elevation receives 1. Less than upper limit, so normal troponin would receive 0. So any score of 3 and less is regarded as low score. For patients who have low score, they can be discharged. But this is depending on case by case, but usually you can discharge these patients. If the scoring system between 4 and 6, the patient should be admitted and receive treatment. For patients more than 7, you have to admit, you have to start treatment, plus you have to send the patient for acute, for primary PCI. What are the treatments for all MI? For all MIs, all acute coronary syndrome, all patients should receive aspirin 300 milligram, either crush or chewing. Before giving aspirin, you have to ask if the patient have history of acute peptic ulcer disease or asthma or allergy to aspirin. Nitrate, either GTN spray or the tablets which is available, also call it Angiseed in our hospital. The dose is 0.5, some of them 0.6 milligram, given sublingually, can retain the tab up to 5 minutes, then throw it. The GTN usually causes headache to the patient. One of the side effects, because of vasodilatation, it causes headache. Oxygen if appropriate. If appropriate, what does that mean? It means if less than 92%. Because you have to maintain the oxygenation between 94 to 98%. If more than 98, if you give oxygen and become 100%, for example, hyperoxia is injurious to the heart. Morphine or diamorphine, or if not available, pethidine, or even a tramal. So for as an antithrombotic, we have given aspirin, but if the patient is having unstable angina or non-STEMI or even STEMI, you also have to add another antiplatelet, which is clopidogrel. Clopidogrel, also call it Plavix. You have to give a dose of 300 milligram. If available, ticagrelor is a better choice than clopidogrel, although associated with more risk of bleeding, but ticagrelor is associated with less post-stent thrombosis if the patient underwent PCI. Anyhow, most our patients receive aspirin 300 milligram, clopidogrel 300 milligram, low molecular weight heparin. The low molecular weight heparin that's been received in our hospital is enoxaparin. Enoxaparin, also call it Clexane. The dose is 100 units per kg twice daily. For example, if a patient is 80 kg, if a patient is 80 kilogram, this patient should receive 8,000 units twice daily subcutaneously. Glycoprotein 2B3A inhibitors received in the cardiac center for high-risk patient. For the pain relief, we have nitrate and morphine, oxygen if appropriate. For the myocardial protection, you have to give beta blocker. But beta blocker, you have to give cautiously, especially if the patient is having inferior MI. In patients with inferior MI, because the blood vessel that supplies the inferior wall is right coronary artery. The right coronary artery supplies the inferior wall, also supplies the IV node and the right ventricle. So sometimes there is right ventricular infarction. There is also IV node infarction if there is proximal obstruction of the artery. So what happens? sometimes it's associated with, as we said, right ventricular infarction. So if there is a right ventricular infarction, there will be hypotension. There will be hypotension. In such patient, the patient should receive normal saline 500 to 1000 ml. And they should not, such patients should not receive nitrate because it causes hypotension. Should not receive beta blocker because it causes hypotension. And also morphine should be given cautiously. Sometimes inferior myocardial infarction also involves the IV node. In these patients, there will be bradycardia. When there is bradycardia, IV node involvement, you might give atropine if the heart rate is less than 45 and associated with symptoms. And do not give beta blocker because beta blocker can lead to bradycardia. If this is not the case, I mean anterior STEMI or lateral STEMI, you can start beta blocker. Example, bisoprolol. Best one is metoprolol, 25 to 50 milligram. Coronary angiography PCI in most patients who have high scoring, more than 7. For the STEMI, or patients who have acute symptoms of MI and new left bundle branch block, or those with high risk of high risk STEMI, the patient should receive emergency reperfusion therapy. Emergency reperfusion therapy composed of two main things, either mechanical or pharmacological by drug. So either mechanical or pharmacological. PCI should be done for any patient with STEMI or high-risk STEMI, but for the STEMI or new left bundle branch block, if the patient came to the hospital, from the door of the hospital until it reaches the PCI needle, until they put a needle for him for the PCI, if the door needle time is less than 120 minutes, expected to be less than 120 minutes, then it's better to do PCI. If more than 120 minutes, you have to start fibrinolytic therapy. The one which is mostly available in our hospital is alteplase. Alteplase, also call it actylase. This is if the patient have delayed going to the PCI center delayedly, or if they have contraindications to PCI, or if they cannot afford the PCI. Avoid delay because time is muscle. With the time, more myocardial damage will happen. So this is left bundle branch block when there is widening of the QRS. When there is widening of the QRS, W-shaped pattern in V1 and M-shaped pattern in V6. This is called left bundle branch block. New onset of this type of ECG is regarded as STEMI. The contraindications to fibrinolytic therapy should be revised before giving thrombolytic therapy. So in summary, you have to recognize the different presentations. You have to start with the ABCD approach and give immediate treatment like aspirin, morphine, GTN, and oxygen if appropriate. Then arrange emergency reperfusion therapy when appropriate and identify high-risk patients for further investigation. Thank you.